As people are trickling, as people are trickling in, and I know there are a bunch of people already online on the webinar. Welcome everybody to Pediatric Grand Rounds. Dr. Hirsch is uh, out of town, I think. So it's my pleasure to welcome people and to introduce our speaker. I'm going to start with our land acknowledgement. And as I say every week when I do this, land acknowledgement, I've always felt a little like it can be very tokenistic, but because the a goal of Grand Rounds, one of the goals of Grand Rounds is really to create community. I actually find it meaningful to mention that we are on the land of the Ramaytush Ohlone people, who were the traditional custodians of this land. And building community is actually an enormous big element of what they stand for. And so we really want to recognize that and thank the Ramaytush Ohlone community for their stewardship and support. Um, and community also means a lot for today's Grand Rounds because I met our speaker, who has the most fabulous name, Dr. Chase Thaddeus Maceo Anderson. I met Dr. Anderson at the Differences Matter orientation that our School of Medicine organizes every year, and I was really honored to be invited. And I sat at the faculty table together with Dr. Anderson, just call them Chase, is what they told me in this little thingy. And we very quickly became a community with the faculty group. And it's just really special to create a community at UCSF so quickly. So I was really pleased by that. And then when I started to understand the work that Dr. Anderson does, I was like, you got to come to Pediatric Grand Rounds. Because Dr. Anderson is a faculty in child and adolescent psychiatry, and he runs the MUSE program for minoritized youth in that department. And he will tell you much more about how that all came to pass and what he's doing in that role. I will briefly tell you that he completed his undergrad education in chemistry at the Massachusetts Institute of Technology and his master's in biological engineering at MIT, and is also a graduate of the Northwestern Feinberg School of Medicine. Um, they, I think it's he and they, yeah, graduated from the adult psychiatry residence at the Massachusetts General Hospital, McLean Hospital, and then the Child and Adolescent Psychiatry Fellowship at UCSF. Their writing has appeared in the New England Journal of Medicine, Nature Mental Health, NPR, Scientific American, In-House Magazine, Wonderman, Snap News, and other news and journal outlets. And in their free time, they enjoy going for long walks, doing queer things, listening to K-pop, reading fantasy books, playing soccer, writing, planning dinners with friends, and dreaming of how we can better the world together. I think that all by itself tells you what a wonderful person Dr. Anderson is. And I'm going to hand it over to you.
Thank you so much for that introduction. And it's really an honor to get to be with all of you. So let's get started. All right, I don't have any disclosures. I really wish I was making tons of money on the side. I'm not. One day, maybe. All right, so what we're going to be talking about today is minority stress in the medical professional, how minority stress affects mental health. So this is a talk that was a 5-minute presentation that I did with a colleague back during residency. It was part of our QI project, and now I expanded it to an hour-long talk. So this is the only time I will say that our QI projects can maybe launch your career. In terms of an overview, part 1 will be a personal vignette to show what minority stress can do to people. Part 2 will be what is minority stress, so some definitions to bring us all to the same page. Part 3 is minority stress in America and in healthcare, so some statistics to keep in your back pocket when people say racism and discrimination don't exist. You can be like, yes, it does. Here are some stats about this. Part 4 will be anecdotes of minority stress that occurred during residency. Part 5 is how do we heal and how we grow. Part 6 will be how can minoritized people protect themselves. A lot of talks don't specifically help minoritized people. They are mainly geared towards white people and giving them knowledge. And so I wanted this talk to have a little bit about what can minoritized people do as well. Part 7 will be future directions of thought. Part 8 is a personal vignette revisited to wrap up the whole story. And then part 9 is a Q&A. In terms of learning objectives, at the end of this presentation, learners will integrate into their practice the ability to specify at least 3 ways in which minority stress affects mental health, assess how minority stress can affect minoritized trainees and faculty in the medical system, identify at least 3 ways in which we can make academic environments safer for minoritized individuals. So before we start with that personal vignette, I am actually very open about my mental health. I live with a history of depression and suicidality, which we will talk about more. I know that can be a touchy topic for some people and activating. So if you ever need to step out while we do this discussion and do this lecture, please feel free to do whatever you need to. I want you all to feel safe and comfortable as we do this. And I will stay after in case anybody needs to process anything that I brought up. My life changed when I came out at age 12. Until then, overall, I'd lived this idyllic little life, one where I was educationally and economically privileged in ways I didn't even know at the time. I hadn't heard the N word yet. I knew the world was hard for gay people from newspapers, but I didn't fully grasp how things were about to change. Through the next years into high school, I was called the N word, homophobic slurs, and I went through bullying because of facets of my identity. Even though I was one of the top students, even though from the outside, many people thought I lived this idyllic little life, even though I made it look good, people didn't know that my smile hid so much. I didn't know what to call it at the time, but I began to develop depression and anxiety. I feared going to school, even though I loved learning. In high school, because of discrimination I faced, I had one suicide attempt. No one knew I wasn't hospitalized. My mom, dad, and sister helped me survive those years in various ways, even as I hid my mental illness. Then I entered college at MIT and my life changed for the better. Not at first, though. Within the first few weeks, I was rejected from a fraternity because I was open about being gay, had to meet with MIT faculty about it, and subsequently failed all my first exams because I developed panic attacks for the first time. I was no longer a stellar student. I was also sure I was going to fail out. This led to my second suicide attempt. Again, no one knew. I was ashamed to openly say what was going on inside, and I thought I was going to end up dead. Yet something different happened. The friends I'd already made at MIT validated my experiences of discrimination, shared their experiences with discrimination and mental illness, how they dreamed about changing the world as well. We bonded tighter together, and we learned how to support each other. We saw each other as more than the characteristics often used to define us and shattered those stereotypes. We became a family where we spoke about topics of diversity regularly and shared our lives with each other. Because of them, I made it my purpose to help others not experience the same issues I had. I got to see what it meant to truly live as well. It wasn't perfect, and there were still instances of discrimination, but it became more rare as time continued, and there was always nearly someone else besides myself who spoke up against such instances. Those friends saved my life. They helped me soar for the first time as I embraced my identity, and we celebrated each other's identities. Because of their friendship, because of my family, without meds or therapy, I entered what I called the golden years right before grad school at MIT, a 2-year period where I didn't have a single depressive symptom or any suicidality. I thought my depression was cured forever. I left MIT with the certainty that America was ready for a shy yet confident, Black, gay, introverted guy nicknamed Dream and a unicorn phoenix by his friends. Medical school, however, was about to disillusion me and bring back the one thing I thought was cured forever. I became class president within the first few weeks of medical school, and things became a slow descent into hell. I was told by a classmate that I probably won class president because I'm Black and gay. I heard how I talked about being minoritized too much. I started to get shut out and shunned, even from events I helped plan with classmates. 6 months in, my depression, anxiety, and suicidality had returned. Every day became about social navigation, balancing class president, finding allies, including our amazing vice dean, certain attendings and deans, educating people constantly about the discrimination they were enacting, taking on certain deans who had discriminatory behaviors, making changes with others, handling schoolwork, and planning my escape from medical school. All the while, my identity fractured. I began to fail exams. I cried alone in my room at night and woke up screaming from nightmares. I couldn't even tell my friends from Boston and family in Seattle what was happening because of the shame I felt and had been made to feel. Because of all of that, I started medications and therapy for the first time. Yet, even with medications, therapy, an abundance of friends in medical school, and alliances built, that didn't stop the flood of constant discrimination that continued to break me. I failed 4 shelf exams in a row. I had never felt or been made to feel more alone. This led to one night in third year where I had plans and intent to suicide. After that night, there were several breakthroughs, including being more open with friends in Boston about how bad medical school was, and I honored my surgery shelf and taught myself further tools to more fully face down discrimination. But I felt like a shell of a person who once dreamed of so much more. Although my psychiatrist, therapist, and I agreed I entered clinical remission in my fourth year, my symptoms flared whenever I experienced discrimination. I couldn't figure out why my depression didn't fit the classic criteria we use in psychiatry, but that remission was enough to hold me steady. I then matched back in Boston at a university where the program director said to me during interviews that she hadn't heard about issues around being Black, but if there were issues, I'd be supported. I raced back to my friends in Boston, hoping to feel truly safe again. In residency, I saw the descent into chaos coming a bit better this time. For my psychiatry rotations for the first 3 months, I was told I was above where I needed to be. I thought I had found safety. Even when an attending who was also minoritized warned me that appearing to be competent and confident as a Black gay male would lead to discrimination and backlash, I thought that couldn't be true. Then, on my internal medicine rotation, I had an attending who kept pimping me in front of colleagues in a way that caused my panic attacks to flare. When I told her this, her pimping worsened. I heard how she'd done the same to other trainees. In the hospital, I was being called the name of the only other Black psychiatry resident who looked nothing like me, asked if I was there as transport. My knowledge and the knowledge of other minoritized people was constantly questioned, and I was disparaged by some patients and staff and saw the same happen to other colleagues. 1 week later found me standing at the sink in the hospital bathroom, crying before rounds, suicidal, having to force myself to go to work and not run away. On her evaluation, the attending said I was unprofessional, was worried about my being a danger to patients, and that my knowledge was far below my peers. Although other evaluations said that I was beyond where I needed to be and praised my professionalism, my program leaders labeled me as unprofessional, rated my knowledge and professionalism below my peers, and I was ignored and told I was the problem when I told one of them about what was happening at the hospitals. I had to do a pseudo remediation with the internal medicine chief resident mornings after working overnight, where senior residents said I excelled. Faculty had supposedly secret meetings about my not wearing a tie and that being unprofessional. I don't wear ties anymore at all. I'd rarely felt more stupid or embarrassed or that I was the problem. My suicidality worsened in frequency and intensity. Because of so many lived experiences, however, this time I knew what to do to survive. With my residency class, we strategized how to handle program leadership and make changes. Then we went to war with our program when we deserved peace and a safe training environment. I set aside the guy who simply wanted to date another guy and have a calm life in order to mentor others, push where I could with faculty, and support my colleagues. I led with vulnerability and used it as power when I and my other colleagues spoke up constantly when we simply wanted to sit in quiet peace and dream upon the stars. This time around, I was open with my old friends from college and family in real time about what was happening, even as I had less time with them because I didn't have the energy. My colleagues set aside many of their dreams as we spoke up constantly and consistently. I restarted my antidepressant, which I had been able to come off of after leaving medical school. I also started therapy again. I wasn't just scared I was going to lose my life, I was constantly terrified as I watched my spirit fade. 1 year later, soon after one morning where my suicidal thoughts became more intense with intent, and I went on to have an attending tell me my work was excellent that day, AKA sometimes nobody knows that somebody's suicidal. We're very bad at telling that. The program director, who hadn't listened to me when I told her how bad things were, was crying as she apologized to me for how she hadn't listened, how she had put me in a horrible position, for how she and the program had hurt myself and others. Then she and I got to work. Every week, we'd meet to discuss aspects of her identity, the program, certain instances of discrimination I'd experienced or classmates experienced. This was all on top of working to be the model minoritized physician. That didn't stop the depression. It didn't stop the daily discrimination I saw or experienced, but it did help to have a leader who validated myself and others who worked to better things. At the same time, I was planning my escape from the program. I also began to speak out about experiences under a pseudonym on Twitter because I wanted people to not feel so alone. When the co-program director, who is now an ally, announced she was going to another program, that solidified my decision to fast track. During interviews, I had better questions this time around, because for minoritized applicants, it's not simply about, oh, this is a great program. It is about where will I be safe? Where will I experience the least discrimination? Faculty at UCSF were the most honest. I matched at UCSF. Then George Floyd was murdered, and people who had enacted discriminatory behaviors were rushing to apologize, invaded my space when I wanted to be left alone. Our program even said how they had hurt people, but never specifically apologized to anyone, and discrimination continued. I and others forgave because we saw it as people having blind spots and enacting learned behaviors from society. But that knowledge didn't stop their rush to that didn't stop the knowledge that their rush to assuage their guilt and these delayed apologies didn't heal my shattered heart or give me back my lost time, peace, dreams, or sense of self. So I geared up to leave with plans to leave academia if fellowship was more of the same, began saying goodbye to my oldest friends and newer friends and mentors, wishing that the program had been safe enough for me to stay in Boston with my friends who I'd promised to be together forever with. So, what does all that have to do with minority stress? So the typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. This is mental and physical health. This term came into being during a seminal paper by Dr. Meyer. It actually had been in play a little bit earlier, but he was the one who brought it forward more. And so he was looking at LGBTQ plus people. And so he was noticing that the teaching had been that maybe queer people are just more likely to be predisposed to depression because of how they're born or because of being gay. What he noted was actually that people are experiencing external stressors that then lead to internal shame and stigma, and then can lead to worsened mental health outcomes and physical health outcomes. So basically change the game of how we think about patient care and how people are impacted by discrimination. A lot of other minoritized groups saw this definition and then started thinking, oh, this applies to us as well. So out of that came the minority stress theory, which is the more elegant explanation. Individuals from oppressed social groups experience excess stress and negative life events because of their non-dominant status or statuses, which can lead to or exacerbate mental health problems. These effects are unique, socioculturally based, and long-lasting, which means they're additive. When I work with the kids and I teach this to them, so this is what we do in the clinic is we teach about this. And so the way I describe it to them is think about getting a paper cut. You get one at the beginning of the day and it's annoying, but you're like, I can heal this or I can put a band-aid on it. That's like me being called like a homophobic slur at the beginning of the day. I'm like, this is really annoying, but I can handle this. Now imagine getting 1,000 paper cuts per day. Eventually you're bleeding all over the place and you don't know how to patch up your wounds that are happening. The other way I describe it to kids in other universities I do this at is I talk about Sailor Moon because I like to watch the Japanese version because it's really good. And the kids always love that. And so she has this thing called the silver crystal, and it encapsulates all of her shine and who she is. And so think about getting a crack in that shine. That's a cracking your sense of self. It starts leaking light all over the place, but you're like, I can patch this up. Imagine getting 1,000 cracks per day. Eventually, your sense of self shatters and you don't know how to put yourself back together. So that's another way to think about it. This also plays out in institutional discrimination. So these are disparities that systematically favor certain groups. This can include housing. Back in the 30s in Chicago, there was this thing called redlining. And so African Americans were only able to buy homes in certain areas and their homes were appraised at lower rates. This actually still plays out even in SF in some ways. This also applies to schooling, employment, health, and justice. So this slide is the minority stress theory written out as a diagram. It's what I draw out with the kids, and they really love having the visual. So I was like, okay, I should add this to my presentation. So this is minority stress for transgender people. What I want you to look at is on the left side, there are these things called, oh, can I use this? Is this happening? Yes. Okay. So we're going to go over to distal stressors first. And so I want you to think of these as external stressors. So these are things in the environment that are leading to issues for people. So this is America doing things to somebody. It's why I use the term minoritized, because when you say minority, it's like the person brought this on themselves. Saying minoritized helps the kids unlink from the fact that they did anything wrong. So in terms of distal stressors for transgender people, first is gender-related discrimination. So this is difficulty getting appropriate healthcare because of one's gender identity. This can be gender-related rejection, so being rejected from family members or friends because of being transgender. This also can be victimization, so verbal or physical harassment because of gender identity specifically, and non-affirmation of gender identity. So using somebody's correct pronouns, they've actually shown in studies that using somebody's correct pronouns can decrease suicide attempts. So all of that in and of itself, those external things can lead to worsened outcomes in terms of physical and mental health, including higher rates of depressive symptoms, substance use, anxiety, and suicidality, sadly. Now, what can also happen is that these external stressors can become internal. So somebody starts out as thinking, I know I'm not the problem. I know that America and how people are acting towards me is the problem. However, like the minority stress theory that I talked about with chipping away at somebody, eventually that person will start to internalize those things, and that becomes proximal stressors. The way I tell kids this is say, like, I think about this as internal. So this can be internalized transphobia, so feeling embarrassed about being transgender, or actually being embarrassed of other transgender people and saying, I'm the right kind of transgender person because I fit in. Also, negative expectations. So expecting it not to be accepted. So even if you meet somebody who has been totally accepting of you being transgender, if you've had negative experiences before, you are more predisposed to worry about somebody else having issues with you being transgender. This also can lead to non-disclosure. So changing the way you walk, sit, talk, and it's also for transgender people known as going stealth. So it's a way of like blending into society. However, that actually creates a lot of cognitive loads for them and a lot of masking where they're trying to like adapt to a society that isn't accepting them. So that can also lead to those outcomes that we talked about before. Now, there's the thing that can block minority stress or mitigate it or actually help people heal. And it's why I show that vignette at the beginning with my college friends, is that there are two big things that can help somebody going through minority stress. The first is pride. And so that's feeling special or unique about one's gender identity. So feeling like happy that you are transgender in and of itself can be helpful. So centering yourself. This can also be community connectedness. So it doesn't have to just be transgender people. It can be anybody who is accepting. So that's why I also showed the pictures from MIT, because most of those kids did not look like me. Or, well, now I guess they're adults too, because we're the same age. But most of them did not look like me. But the fact that they were accepting and let me be myself was what helped me heal. And so these are called resilience factors. For the kids, I call them strengths-based factors because I don't want them to feel like you have to be resilient enough. I want them to know that you are strong because of these things. How does minority stress play out in America and in healthcare? In terms of some racial statistics, a study by Randy T. Lee looked at major lifetime discrimination and saw that 48.9% of African Americans had experienced major lifetime discrimination versus 30.9% of white people. It is high for white people because women are included in that category as well. In terms of day-to-day discrimination, 44.4% of white people said they'd never experienced day-to-day discrimination. Only 8.8% of African Americans were able to say the same. This also sadly plays out in terms of pay discrepancies. So they looked at people who entered at the same levels of education and were doing the same amount of work. And what they noted were pay discrepancies that were noted at 57% for African Americans, 32% for Hispanic Americans, 31% for Native Americans, 25% for Asian Americans, and 13% for white people. The slide is a little bit busy, but I want to draw your eye to the right-hand column. And this is yes, regularly experiencing discrimination. So for white people, it's noted at 3.82%. For every racially minoritized category or grouping, it is higher. So for Black people, it's 11.23%. For Asian Americans, it's 10.85%, and so on and so forth. In terms of some statistics for LGBTQ plus people, so they noted that youth identifying as LGBTQ plus, they look at different high schools across the country and they do this biannually. All sexually minoritized adolescents reported higher rates of violence victimization. This included feeling unsafe, being forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. An example of this, just to bring home the statistics, for gay males versus heterosexual males, bullying was noted at 27.7% versus 14.6%. That's almost double. Lesbians also reported higher use of cigarettes and marijuana use, and the prevalence of cocaine, heroin, methamphetamines, ecstasy, and inhalants were higher in sexual minority groups. So one thing to keep in mind, and the thing I love about psychiatry, is the question why. That is one of the most important questions we can ask somebody. So not shaming somebody when they say they're using substances and instead asking why. For a lot of the kids that I work with and people I have met during residency and other places, they are using substances if they're minoritized because they were not given coping skills to help them deal with the minority stress that they were experiencing. And they already feel enough shame about using substances because of that. This also sadly plays out in the prevalence of suicide attempts. So again, it's 5 different high schools. So that's why the numbers on the right will be a little different. For lesbians and gay people, it was 24.3% versus 13.1% for heterosexual people. For bisexual people, it was 28.3% versus 23.2%. When people said that they were unsure, the statistics actually reverse. It's 12.4% versus 14.9%. The reason it was unsure was reversed is because people who said they were unsure weren't displaying stereotypically gay traits and may not have come out at the time. And so they weren't getting bullied. So the drawbacks of the study, they saw high dropout rates, and they actually say that there's an underestimation. So if you think about it, when kids come out, a lot of them come out at very early ages. We actually develop our sexual orientation earlier than our straight counterparts in a lot of cases. So 6, 7, things like that. And so what can happen is that those kids were then more predisposed to discrimination earlier on without coping skills. And so some of those kids either suicided or they did not make it to high school because they dropped out by that point. And since the 2016 election, sadly, things have gotten worse. The FBI keeps track of the hate crimes that are going across the country. And they've noted that for misogyny, as well as race, as well as religion, as well as sexual orientation, we are seeing an increase in hate crimes consistently. So I know this talk is a little bit of a downer at the beginning. I swear it gets better at the end. So for Asian American sexual minorities, some of the studies I was talking about before looked at mainly white people or white LGBTQ plus samples. So research demonstrated that external racial stressors among Asian American sexually minoritized individuals resulted in greater psychological distress. A study done at the University of Tennessee noted that Asian American LGBTQ plus persons experience rejection, prejudice, discrimination from the overall LGBTQ plus community. So something important to ask kids when you're working with them is we ask about community and family, but asking how accepted they are in each aspect of their family as well as in their community. Because my being African American inside of like a white culture for queerness is actually more dangerous sometimes because of things that I hear and discrimination that I have faced. So thinking about how our different aspects of our identity can clash in different types of cultures. They also saw increased internalized heterosexism or internalized homophobia because of violating traditional Asian values such as harmony and complementarity. So thinking about how cultures can clash and how they can blend together in very beautiful ways too. Among 314 LGBTQ plus people of color studied, 58 of whom were Asian American, they saw higher rates of depression, perceived stress, and need for acceptance. They also saw this thing called ethnosexual mythology. So this is fetishizing by a different name. The example I usually give when I give this talk is when I would open Grindr, because I was also like on dating apps and other things at like med school, because I was sad and I needed to find somebody. So what happened was sometimes people would open their comments with like, "I love your black skin," or like, "I love how black people smell." And I was like, this is not the opener you think it is. So that is something that can be happening to your kids when they're using social media by just interacting with people. Along with this comes the need to talk about intersectionality. So this is the interconnected nature of social categorizations such as race, class, and gender, which create overlapping and interdependent systems of discrimination and disadvantage or advantages. The example I give around this is I stand before you as somebody who's queer and African American. When I walk by police people, I used to get very scared. And so what I did was I would use my queerness to compensate. And so what I would do is I would talk in a higher pitch. My pitch is actually pretty deep. Some people from our medicine group actually like knows that my voice changed in the past couple of months because I finally was able to relax it after 22 years with my therapist being like, "Where do you talk?" And I was like, "I talk up here." And he's like, "That's wrong. It's here." And I like talked down here in my chest and it reverberates, and I cried during the session. So people change even late in life. But it's also to show that like I was so scared about being an African American person with a deeper voice because I thought that would be threatening. So people can use different facets of their identity in order to compensate and protect themselves. Along with this comes the intersectionality paradox. So the thinking was that if you were of a higher socioeconomic standing and you were racially minoritized, maybe that would help you. They have proven through studies that doesn't work. So they actually looked at African American women with higher levels of education. They saw higher rates of depression than white women at the same level. So racism is the problem, basically. And I don't want you to memorize any of these terms that I'm sharing. This is all to build awareness. And because I'll talk about it later, but awareness in and of itself can lead to decreased bullying and decreased depression for people. So that's why you do not need to memorize any of this. Along with this comes the multiple jeopardy perspective. So it's known as the multiple disadvantages approach, also known as the multiple hierarchy stratification. So I don't like this term, but I just like am bringing it forth so we're all aware. So it's assigning low and high status traits to different facets of identity. So an Asian American bisexual female in America is the example they give. They say it would be 3 hits for low status traits. It's very rude. The reverse would be a white heterosexual male, and that would be assumed to be the jackpot in America with 3 high status traits. Again, I don't know who came up with this. It's still like the rudest thing ever. However, one of the things that we need to think about too is that we need to take a step back. Just because somebody is a white heterosexual male does not mean that they haven't gone through other things that have disadvantaged them, including things around like socioeconomic standing, including things like bullying. So that is again why I love psychiatry, because it's thinking about how did somebody get to us and how are they existing as a person. So, how does minority stress regarding patients play out? So I'm going to start with some definitions first. The first is microaggressions, which many of us have heard about. So these are broadly defined as behaviors that ambiguously disempower racial minorities. However, that's an umbrella term, and there are three categories underneath that. The first is microassaults. So these are explicit acts of racism, saying someone is of lesser worth. The next is micro insults, saying someone didn't earn their position. The last is micro invalidation, saying we're all the same. We're not all the same, we are all different. And it's recognizing that and working together. Along with this comes healthcare microaggressions. So these originate from this term called aversive racism, saying that we aren't prejudiced, we don't have racist tendencies. Along with this comes this thing called institutional betrayal. It's like the coolest term I've ever heard of. However, it's a horrible thing. It's normalization of bad behavior, basically. The example that is given is if a med student comes to an attending or med student comes to a dean and says an attending was discriminatory towards me, how that dean responds will actually portend how the person's mental health goes in a lot of ways. So if the dean responds appropriately and says, I will take this attending from service and they will have to either like go through remediation or they will not work with students again, that med student's mental health feels protected because they feel protected by their university, and then their mental health will be better. If, however, and I showed you that example in my vignette at the beginning, the dean responds inappropriately and says, why are you the problem? That medical student's mental health will actually be much worse. So thinking about the power that we have to help people who are in the hierarchy below us, even though I don't like the hierarchy, I think about it as horizontal, but we're working with what we have. So in 2017, Fitzgerald looked at vignettes to examine influence of patient characteristics on attitudes, diagnoses, and treatment decisions. What they saw was nearly all, so 35 out of the 42 articles, found evidence of implicit bias. This was bias around race, age, socioeconomic standing, mental illness, weight, having AIDS, patients who've experienced brain injuries, people who use intravenous substances, disability, social circumstance, and gender. They actually saw the same levels of implicit bias as the wider population. So if you took America and shrunk it down to the size of a hospital, you'd see the same rates of discrimination playing out. And when physicians were less certain of coronary artery disease diagnoses for middle-aged women, they were more likely to give those women mental health diagnoses compared to men. And as I talked about before, intersectionality can actually play a large role in protection. So how does this play out regarding residents? Lisi in 2016, which is one of the coolest articles I've ever read, looked at bullying. So repeated acts or practices directed at one or more workers, unwanted by the victim, done deliberately or unconsciously, but clearly cause offense, humiliation, and distress, and may interfere with job performance and or cause unpleasant working environments. Examples of this are unjustified criticism, humiliation in front of colleagues, intimidatory use of discipline or competence procedures, undermining personal integrity, and shifting goalposts. Shifting goalposts is this thing where if a med student comes to an attending on the first day and says, how do I achieve honors? Then the attending says, you need to do X, Y, and Z. Med student goes and does X, Y, and Z. Attending will then say, you need to do X, Y, and Z, and also flawlessly do A, B, and C. Med student does X, Y, and Z, A, B, and C. Then the attending says, you also need to do D, E, and F, and you need to be better than you were for X, Y, Z, A, B, and C. So they're moving the goal line so that student will never achieve honors. 69.8% of residents in the US have experienced workplace abuse. It's actually higher now. This study was a little bit older. The most common form of abuse was verbal in nature. And in terms of types of resident mistreatment or themes that they saw hierarchy. It's why I tell everybody to call me Chase, from staff on down to the kids, because I want everybody to know we're, as much as possible, trying to flatten the hierarchy. Silence, incognizance, also fear. So 79% were afraid to report something, even if they knew that would be helpful. They were afraid to report because they'd either heard about negative experiences of reporting or had heard about things from other hospitals even. There's also a lot of acceptance and denial. So, oh, what I went through isn't that bad, or everybody goes through it. I'm just going through it now for this moment and I'll be okay. There's also a legacy of abuse. So if a med student is abused by an attending or a supervisor, they are more likely to go on and be an abusive supervisor later on. So thinking about how do we stop that legacy of abuse that's occurring in medicine. Lisi also looked at the sequela of resident mistreatment that plays out on the individual and systemic level. There's a cost to the system with higher rates of medical errors, harm to patients, and dissolution of care. 67% of who witnessed disruptive behavior felt it contributed to adverse events. There's also a cost to the individual with higher burnout rates, thoughts of desertion, depression. They actually have noted in studies that there's PTSD like symptoms that it can occur. I told you all about how I used to have nightmares and things like that and wake up screaming. Actually, during my residency, when COVID happened and I didn't have to go in the hospital, I felt immediately much better. And then when I'd have to go into my ED shift, I started feeling nauseous and I felt as though I couldn't breathe. So I would have panic attacks on the way into the hospital. So I had the avoidance part of PTSD as well and intrusive thoughts. There's also higher rates of substance use and suicidal ideation. 20% who said they would not pursue medicine again and would advise others not to pursue. So regarding minoritized trainees, unsurprisingly, it's worse. So Justin Bullock, who I don't know if some of you know him, but he is one of the most spectacular humans I have ever gotten to interact with. He used to be at UCSF. He's now at his fellowship for nephrology at UW. He does beautiful pieces about living with bipolar disorder, as well as his own suicidal ideation. And he's African American and gay too. So I would highly recommend reading his pieces. He has some in NEJM, and he does a lot around medical education and how we can make it better, and to point out and give us verbiage to what's going on inside of medical education that is hurting people. So again, like, beautiful person. And I always give him a shout out. So, all right. So he looked at this thing called like stereotype threat, and I'll get into it in a second. But he was looking at minoritized fourth year medical students. And so stereotype threat, I want you to think about minority stress as an outside force becoming internal. Stereotype threat is an internal force becoming external. So you worry about when you meet somebody that you're going to fit into their stereotypes. So you start to change how you act, which causes you to have extra cognitive loads because you're trying to adapt to all these environments because of what you worry that people might think about you. So again, it was external and became internal, but this becomes more internal and then becomes external, basically, is how I think about it. They also looked at supervisor biases and possibly poor prior academic training. They noted that stereotype threat can be triggered by standing out or being seen as standing out, also reliving past experiences. So even if you go to a rotation that is great for you, if you had a negative rotation before, you are already predisposed to be more nervous about your next rotation. They also saw that even witnessing microaggressions, there's this thing called by proxy trauma. So if you see somebody else going through something and you resonate with them in any way, it can actually cause you to have depression symptoms and anxiety as well. They noted that non-white students received less favorable med student performance evaluations and lower clerkship grades as well. Let's go through the anecdotes. These are things that myself and my colleague, Mark Busunian, when we put this presentation together, we gathered from other staff, faculty, as well as patients. So blank, this was a nurse voicing concern that a Black patient was dangerous because they were listening to rap music loudly while pacing the unit. This one is a friend who's a social worker who is Black and queer. He still remembers this event and how hurtful it was. An elderly Hispanic man was admitted for dementia, psychosis, and paranoia. The treatment team was rounding with the patient in the ICU. The patient became very agitated and angry because in his psychosis, he believed I had assaulted him at the facility where he lives. The Spanish interpreter reported that the patient was making racial statements and wanted me to leave the room, not knowing how to correctly respond. And this is a different team with a different resident attending. The resident gave me a look that seemed to suggest that for the sake of the interview, I should leave. Feeling shocked by the resident's response and lack of response from the attending, I felt I had to do what was being asked. Needless to say, I felt unsupported, stigmatized, and invalidated. I believe the resident and or the attending should have told the patient I was part of the team and would need to stay. So this is thinking about how we protect our team members. And one of the things is this patient was in a unit. And so why did they not step out at that moment and say, we'll come back when we're able to engage in a different way? That patient was completely safe. The other thing is that this brings up something that happens in psychiatry and in medicine in general of, oh, well, the patient's having a hard time. One of my colleagues then went and looked up in the DSM just to like glance through it, which is our diagnostic manual, and was like, I don't see racism towards people as being part of the depression criteria. So he was a little bit more sassy at that time. I was like, that's bold. But it brings up an excellent point that racism is not one of the criterion we use in patient care. So why are we letting that happen? And if that's happening to us during like meetings, what are they doing to other people outside of the hospital as well? So how do we protect our team is very important to think about. We also noted differences in attending evaluations when colleagues stated that minoritized colleagues worked twice as hard and were twice as good. People who are minoritized being interrupted by attendings when others who are not minoritized weren't interrupted. There's also this thing called the minority tax. So when somebody who's diverse comes into a university, they are often tasked with helping with diversity efforts. This includes running groups. This includes speaking about diversity. I know I'm speaking about diversity right now, but this is my job and I love it and I know how to do this. Some people are tasked with this without given extra pay. They're not given extra time to do any of that. So that's what the minority tax is. There's also tokenization. So this is somebody coming into a university and then they get photographed and then their photograph shows up on 20 different parts of the website to say that the university is diverse. So it's making somebody just a figurehead basically, but again, not giving them the time and resources needed to make changes. We also had an attending saying he had worked well with other African Americans before and they worked so well together. This was not true when checked with other African Americans. So perception and intent are also important. Wait staff who had been minoritized being told by a white patient that they could finish the food left on a patient's tray. We also noted constant misgendering of transgender patients and saying when rooming them, well, they're not actually a female. We need to think about the safety of other patients who have trauma from men. Staff sometimes saying that clearly that person has a personality disorder, and this often occurs with LGBTQ plus patients. So thinking about our documentation and how we actually diagnose is extremely important. A lot of African-American people are overdiagnosed with schizophrenia, and a lot of minoritized people are diagnosed with bipolar disorder. I have received some of those patients and gotten to work with them, and those diagnoses are inaccurate, and they've been put on many medications that were antipsychotics or had different things that were pretty dangerous for them. And so thinking about how we actually diagnose people and what criteria we use and how our own biases can play into diagnosing people is important. So hearing that a patient is difficult or aggressive, and sure enough, they were a minoritized person, looking at notes and seeing how race is brought into the one-liners for specific patients. So if you think about it, we often don't say 58-year-old white person, but we will say 28-year-old African-American person. So why are we predisposing people to think a certain way about patients before we even step into the room? And if we are going to bring up race, why are we not doing it for everybody? So I do not have an answer for all of that, but it's just something for us to think about. Also looking at I already just said that. So staff and patients noting how there are no pictures of minoritized physicians or staff on the wall. So thinking about how often are people who are minoritized actually represented? How do we show things other than the nuclear white family inside of the hospital setting? So how do we help and how do we grow? The first thing we do is we ask. So when Mark and I did this, we didn't have the caveat to it. And then later on, we were like, oh my God, we don't want people asking us this mess all the time because we're tired. So there's a caveat. You always need to give somebody an out if you do bring up this topic. The way that I do it with the kids that I work with is we actually ask about minority stress during the first intake. And what I'll do is I'll ask about their race and ethnicity and sexual orientation. Sexual orientation and pronouns I ask privately because they might not be out to their family members yet. And I want to make sure how documentation is done for them because other people can see their notes and they might only feel comfortable telling me that they're queer or something like that. So once I ask them about those things, then later on in the conversation, I will say, because you said you're African American and gay, we know that America's messy, and the kids will usually laugh at that. And then I will say, you may have experienced things about your identity, specific to your identity, that have made your depression or anxiety worse. You do not have to tell me more unless you want to, but is this a yes or a no? And then they will tell me from there. And then I will also say, if you want to talk about it, we can talk about it more, but know that you never need to until you are ready. I have one kid who he is now 22 and amazing. And when we first met, I asked him this question. He was like, I'm not ready to talk about it. 2 years later, he came to me. He's like, I remember 2 years ago that you asked me about this and now I'm ready. And now he comes into appointments and he's like, yeah, so this minority stress that I was experiencing, from this person, it's leading to my substance use and causing this traumatic reaction. And I'm like, your verbiage is so different from when I was that age. So kids will remember these things as well. So even small little things to help them open up can be very pivotal in their lives. We also need to educate ourselves and protect minoritized people, also becoming actual allies. So posting a black square to Twitter is symbolic, but also what are we doing in terms of policies? We also need to come at this from humility, from seeking to understand and truly converse. So I still get things wrong. This is my life's work and I still get things wrong. And I apologize to the kids when I do, because we are here to learn together and grow together. We are here to work together. So it is okay that we're going to make mistakes. It's embracing them when they do happen. We also believe minoritized individuals when they bring these issues forward. So how do we heal? Lisi, again, this is like, again, one of the best articles I've ever read. They looked at how to actually help people heal from bullying and things like that. And so they noted that education and awareness, so all of you coming to this talk, actually leads to decreased bullying because you're more aware. Also, team-based care at all levels led to a reduction in the hierarchy, and good leadership, no surprises here, led to better prevention and protection and defined a better culture. They also saw that interphysician support led to better mentoring and fostered a better community. They also saw the need for confidential mental health services. So sometimes when I talk to medical students about this or at other universities, what I actually bring up is the idea of why is there not an opt-out medical service or like mental health service? So you come into a university and you are assigned a therapist or a psychiatrist, or you get to pick one. So then you're already ready in case something does happen. You don't have to use them, but why are we making people scramble and find a psychiatrist when it takes about 6 months sometimes, if not longer, to actually find somebody? So thinking about how do we set that up for people so they don't have to scramble when they actually are in crisis. And I think like everybody should have a therapist because like it's great to talk to somebody else. They also saw the need to develop a curriculum that tackles the hidden curriculum. So half of medicine is learning about social navigation, and the other half is about medical facts. So why are we teaching about one and not about the other? And in worst case scenarios, they need to build exit strategies. So I had to build my own exit strategies out of universities. Why was I not able to go to the deans and say, hey, this university is deeply problematic and I've tried my best. Like, I have. Here's X, Y, and Z of how I tried. I need to go somewhere else. Why was that not set up as a thing that could happen more readily for people without blowback? So just something to think about. We also need to recognize, name, and understand these attitudes and actions, identify our own implicit biases. We all have biases. We're born into America, or we live in America, or we're born into this society in our world. Everybody has implicit biases. It's about how do we catch them and how do we work with them and make sure that they don't affect others. We also need diversity training that's not only about diversity now. So in terms of that, they actually were thinking about like, how do we teach about the harms that medical schools and medical training has done to people and patients so we can learn from our mistakes and not repeat them. We also need continued research that address patients' social risk factors and needs and diversify the healthcare workforce. This also has a caveat because at the beginning we were like, oh, if you just bring in more minoritized trainees, things will get better. What has been noted is that if you just bring in more minoritized trainees and you don't give them the power or privilege to change things, what actually happens is it's a leaky pipeline. So they will go into the university, make a lot of changes that help a lot of people. They will burn themselves out in either. So we know that our suicide rate for physicians is twice that of the general population, or they will leave that university after. So if you look at residency trainings to faculty, you will notice that a lot of minoritized people leave if it's not a safe university. So how do we diversify the workforce in terms of bringing in people who are at higher levels that can actually help shepherd people through as well? And there's further reading, but like you all have enough work to do. So like, don't worry about that. If you really want it, I can send it to you. So how can minoritized people protect themselves? So thank the goddess and Queen Beyonce, there are actually techniques and strategies to protect oneself that have proved promising. So in 134 studies about discrimination and health outcomes, they saw that reflective coping and problem-solving skills were actually the best way to help somebody. And this applies to kids, this applies to everybody. So if you can actually give space for somebody to share their emotions about an event and then say, how do you want to strategize to help you move forward? That is one of the best things that you can do for somebody because it gives them a moment to say, this happened to me and I feel alone. And then what do I do about it?
So is that essentially CBT?
Yeah. So partially CBT, you can come in it through different routes and stuff. So some of my kids that I work with they like psychodynamic therapy instead. So I let them do like their feelings and everything. And then sometimes I'll pivot a little bit and be like, how do you want to actually like navigate this situation? So it can be adapted to different types of therapy, but CBT would be one of the mainstays, as well as DBT as well. So dialectic behavioral therapy, where you were learning skills about how to hold competing ideas and emotions and then wise mind your way through it is what it's called. Excellent question. Yeah, thank you. So they saw that other things that helped were cognitive restructuring, expression of emotion, and social support seeking. They also saw the importance of community and identity centrality. So feeling centered in your identity. This goes back to community and pride that I was talking about during like my earlier part of the talk. They also saw some other things, including humor and armoring and even withdrawing sometimes. So sometimes not being in a situation can be helpful to people. No, Chase, we need specifics. So, the American Psychological Association actually has this article called Disarming Racial Microaggressions. And I'm going to go through these a little bit quickly, but because I don't want to overwhelm all of you, but there are different techniques that can help. So, the first is making the invisible visible. So, this would be my getting onto an elevator and seeing somebody who is not of my race pulling their like purse closer at that moment. I would say, is there something about me that's making you uncomfortable? Again, all of these techniques can be like some of them can be dangerous in certain situations. So it's knowing and practicing beforehand, because what can happen during these situations is you actually can have fight or flight or freeze. And so practicing them beforehand will help you with running that script when you encounter these situations. And when I work with the kids, we actually will run these situations and scenarios. So there's also disarming the microaggression. So I don't agree with what you just said. Educating the offender. So actually saying, I know you mean well, but we're more concerned about someone's abilities as a human being than physical appearance. So actually calling out what happened and saying, this is not what we're going to focus on. Seeking external intervention. So that was my going to the vice dean and saying, there's a deeply problematic thing happening at this university. Setting clear limits. We don't tolerate that kind of language. Redirecting and reframing. So I recognize that this group may be different, but I want you to know that we're worried about something else instead. There's also a longer article called Disarming Racial Microaggressions, Microintervention Strategies for Targets, White Allies, and Bystanders. This is actually the like flow chart that they made. It's like the coolest thing I've ever seen. Again, I like nerd out about this stuff. So like, thank you for bearing with me. But they actually like made a full chart of how to help people through discrimination. Okay, we're going to skip future directions of thought because I've already kind of gone over it a little bit. A personal vignette revisited. So how did that vignette we began with end? I flew to San Francisco and cried in my apartment that night from missing my friends, relief that I escaped an unsafe environment, and over the loss of my once dream to stay in Boston forever with my friends. Over the next weeks, I took time to myself to reflect, to look to the future. A few weeks later, I revealed my true identity on Twitter because I felt safe, and then I began my fellowship. Within 2 weeks of my arrival, my depression and suicidality vanished, and I entered the third remission period in my life. So I told a couple people when I entered here, but I'm in my 7th episode right now. So I've been having suicidality for the past couple weeks or so. I am totally safe, and my whole cohort knows, and my colleagues and my friends. And I've actually been open about it on Twitter and saying this is how I'm walking through my suicidality this time, and this is what's different this time around, and what my suicidality represents that I need to heal about myself. And my like program leadership also knows, and they know that I have, if I cannot run my 10 permutations that I have for each patient for every day, then I tell them that I need to step away from work. I've never had to do that, but some people sometimes worry about like, can I disclose this? And other people say like, I've had messages on Twitter, over hundreds and hundreds of them have been great, but I do get messages that say like, you shouldn't be taking care of patients. And I'm like, you have no idea about the nuance that I like bring to the table or how my suicidality actually shows up. And I just ignore those comments now. But that is what can happen when you disclose. So I'm telling all of you right now that this is my 7th episode, and each one I get faster and better about handling it. And like I'm giving rounds right now. So this is to give a little bit of hope too, if any of you are going through that, that is not like the end of your story in any way. And I'm almost out of the episode. Everything's getting better. It's great. So I found a program director where my program leadership said to me, you never have to take on issues with racism if you don't want to. It's not your job to handle these things, and back that up with words and actions. I got to work with co-fellows who spoke up around instances of discrimination before I had to say a word. I had the opportunity to work with mentors who looked like me, who focused on what really matters, helping kids, their families, and our world. After 7 years, I finally found overall safety and broad support in academia. I began to fully live again. I got to again become more fully that unicorn phoenix nicknamed Dream by his friends years ago. I'm different but similar in the important ways. I've had time to work on articles around minority stress, do lectures at other universities and lectures here, engage around topics of diversity by choice and not for survival, skip down the street listening to K-pop, go queer clubbing, sit and simply breathe, and build a family with old friends and new, and be fully present when I see old friends in Boston and my family in Seattle. I've been able to see just how far someone can fly when not constantly barraged by discrimination. I found an environment like the one I had in college and graduate school where I feel safe. The scars are healing and it will take time, but those cracks are healing and I couldn't feel more fortunate. Because of all of that, I graduated 2 years ago from fellowship at UCSF and decided to stay as faculty as an assistant professor. Some of you know what I've been shortening that to, but think about what assistant professor could be shortened to. It's like very inappropriate, but everybody on Twitter laughs about it. Part of my work with others is being medical director for a program we built and are expanding specifically for minoritized youth that involves trauma-focused cognitive behavioral therapy, healing from discriminatory trauma, peer groups for parents and kids around discrimination and mental health. Those groups are set to start in a couple of weeks, and collaborations with other clinics. In honor of the family, friends, mentors, and people I love who saved my life once upon a time, the clinic is named after our group nickname that started in college and graduate school, which was the Muses. Thus, our team has called our program that opened July 2023, the Muses Program for Minoritized Youth. And I'm excited to see where these new chapters that I get to write take all of us. So this is with special thanks to Mark, because he was my partner when we first did this, and then everybody else who invited me today. Okay, that's everything.
So much. We have a few minutes for questions. I want to start actually, Dr. Lee Atkinson-McAvoy, who is our for ideas, which is our way of saying diversity, equity, inclusion, and it's actually a much more elegant, because it really focuses more on anti-racism and anti-oppression, just simply DEI. She just wants to say, thank you, Chase, for sharing your personal story and the scholarly analysis of how minority stress shows up and impacts health. I appreciate the specifics of how we can lead this patient care. I am grateful. I echo that.
Thank you very much for saying that. It's truly an honor to be with all of you. And I didn't think I would get emotional, but to be here is deeply meaningful. And I'm so happy to be alive with all of you. So thank you. So always tell people, I know some people need to process this sometimes because they're like, dang, that's my life. And like, I need to sit with this. Or it's like, oh, I have a lot to learn and do and help people. So if questions come up and you want to talk about them later, you can always email me as well, because I know it's sometimes hard to also talk about this in front of everybody. So I want to be respectful around that too.
You again, it's really special to have you here today. Me, others, and for taking care of a group of children that really deserve some.
Thank you.
Thank you.
Thank you all.